Okay, welcome to this ECIST webinar. And the webinar today is about something really exciting, Formula One Frailty. And we've got our clinical director, Jyothi Nippani, who has worked with ECIST for a number of years, but also she has a day job, which is Associate Medical Director for Service Improvement for the Foundation Group, which covers South Warwickshire, Wye Valley and George Eliot. So Jyothi, over to you.
Thank you, Pete. Thank you and good afternoon or good evening, everybody. What I'll do is for the next few minutes, take you through a journey that we undertook in managing our frail older patients. I call it Formula One Frailty because you'll see why I did that in the course of my presentation. It just is that art of pit stop working, which was very similar to the Formula One, what happens on the Formula One racetrack. So let's start very quickly with some facts about the frail older person. The first one is that deconditioning associated with prolonged stays is harmful. We all know that. So any pathway really needs to address this robustly. So the shorter the patient stay in the hospital, the better it is. Now, the second fact is that the majority of them are brought in by ambulance, and this is really important. And it's important because patients brought in by ambulance are already triaged in a way. They have been assessed by the paramedics and they have already been classified in the paramedics language as big sick or small sick. Now, big sick still needs to go into the ED. They need to go, have the care that is given in the EDs. But the small sick or the medium sick are the ones that we can pull our frail patients from into a different pathway. So it is really important for streaming that we can use the assessment done by the paramedics already. The other most important thing is that when paramedics bring patients from ED, there's a lot of collateral history they collect because they brought them from the patient's home. And a lot of this is usually lost in translation if they go via a long journey through ED, acute medicine, and then come to frailty. So if the team that is going to look after the patients captures this collateral history directly from the paramedics, you don't lose a lot of detail. And that's another good reason why it's important to register that in the brain. The next fact is that adequate assessment of the frail older patient actually involves multiple professional groups, and you'll see in the subsequent slides as to how many groups of professionals are actually involved in their care. And the care also takes usually 4 to 6 hours for each patient. So in a busy ED, having so many professional groups walking around, adding to the crowded ED that's already crowded with our patients and their own staff, and also taking away the, occupying cubicles for 4 to 6 hours while we're trying to get a management plan is not the best thing to happen in an ED. The next thing is that the care of the older patient in acute hospitals is very nurse resource intensive. So they need a lot of care, they need to be taken to the toilet, they need to be given their medications, they often need to be fed. So there's a lot of nursing care that's involved. So even if we decrease the admissions by a few number, like a handful of admissions, you release a lot of nursing capacity, which is very useful. And we often underestimate how well patients can manage in their own home. And so the more the care that is provided in their own home, the better it is for the patients. So keeping these things in mind, I'll just take you to this next slide, which just proves some of the things which I've spoken in the previous slide. So this is a GIRF, to get it right first time slide from the ED GIRF presentation, and it just shows the relationship between the capacity in ED and the flow. So in a typical ED or in a ED where there are 20 cubicles, if each patient spends around 2 hours in each cubicle, then they can get through 240 patients in a day. Now, in the same ED, if patients are spending more time in the cubicles, like 3 hours, 4 hours, or 5 hours, less number of patients can be turned over in that ED. So what happens to the rest of the patients is they end up going into the corridors. So, and typically our frail patients are at that end of the spectrum where they take 4 to 5 hours to be assessed. So they will be occupying cubicles for 4 to 5 hours. So again, just to prove the point that ED, a busy ED especially, is not the right environment for frailty assessment. This is another slide from the National Audit Office, which gives the relationship between the emergency bed days and the emergency admissions, and stratified by age group. And what it simply shows is something which we already know, is the admissions in the younger age group below 65 are more, but they occupy less bed days. The admissions in the over 75 are less, but as you can see, they have the most bed days. And the over 75s who occupy less bed days are very few. So there are not a lot of patients who actually are in the over 75 age group who are occupying very few beds. So most of the patients who are actually admitted are occupying a longer length of stay. Now, so if we drop the admissions in this age group, you proportionately gain more bed days. So less admissions in this age group, you can see that proportionately more bed days are gained, and they release a lot of nursing time. And so it's useful to know that, so that we can try and minimize the admissions in that age group. Now, the principles we used are getting the patient to see the right team first time, which makes sense, matching the workload to the workforce availability. And I'll show you with some graphs how we did that. Value stream mapping, and when we talk about value, we're talking about value for the patient. So it's a very patient-centered pathway, minimizing the time for the patient in the hospital. So it is not what works for ED, what works for acute medicine, or what works for the frailty team. It is pretty much what is right for the patient. And then creating an environment which makes a multidisciplinary team, the communication within an MDT, very easy and real time. When there's a big MDT, a sequential communication where one team hands over to another, one after another, is not ideal. It needs to be, everyone needs to be communicating simultaneously with each other real time. And the pit stop working pattern actually helps with that. Now, coming to a few slides on data which helped us design our pathway. This slide shows that in South Warwickshire Hospital, we have A&E attendances over 75, and the busiest time for the attendances is between 8 in the morning and 8 at night. So if the team if the patients in this age group have to come to the right team first time, then the team has to work these hours to be able to see the patients as soon as they arrive. Otherwise, they'll miss them. Now, the referral source in this age group is two. They're either self-referred or they are GP referred. Now, the self-referral peak was in the morning, and the GP referral peak was in the evening. And as you can see, that peak sharply comes down at 8 o'clock at night. So in order to capture this whole patient group, this team needed to work from 8 to 8. And the majority of the patients are being brought in via ambulance, whether they are self-referred carers calling the ambulances, or even the GP-referred ones are brought in via ambulances. So in some ways, as I said, the triage is already done, and very few patients are actually coming using their own transport, who are perhaps not triaged as well as the ones brought in via ambulance. Now, our frailty pathway in summary, it was like this. This is the patients coming from home, brought in via ambulance, being dropped off at the ED at the triage point, and we have the frailty team waiting there and at the point where they get dropped off, and they get picked up and miss out the ED part of the journey, the acute assessment part of the journey, and they go straight to the frailty ward. Now, the community response in the past was mainly around the long stay wards. So they were looking after the discharges from the long stay wards. So we moved that response from the long stay to the frailty assessment. So we asked them to concentrate on the short stay ward and not the long stay ward, because over a course of time, the need for that would come down if you are able to send patients home quicker and quicker. So the interventions, as I said, and the reasons for interventions I have been talking about are, the first one was extended day working. So the team was working from 8 to 8 instead of 9 to 5 as they did previously. This was to match with the pre-arrival times as we saw in the data. And as I said, they were selecting the patients from the ambulance drop-off because of the reasons I said in the previous slide. And from there, they picked up 2 categories of patients, the ones who they could send home on the same day, and the other category were those who they assessed to have a short stay. The long stay ones, the very sick ones, still went through the normal route via ED and acute medicine. So the 2 groups who came to us were the same day emergency care frailty and the short stay frailty. And this is where the ACP in the ambulance drop-off area, what they learned from the paramedics and their own assessment on eyeballing helped to pick the patients, the right patients. And in the pit stop working pattern, I'll show you in a minute. And the team had control on the short stay frailty beds. So of all the patients that the ACPs pulled from the ambulance drop-off to go into this frailty assessment area, half of them could go home the same day. Another half would need admission in a short stay bedded area. Now, it's really important that this team has got control on those beds. The reason being, if there are patients who need admitting, cannot be admitted straight into those beds, then you automatically block the frailty assessment area and you can't pull more patients from ED. So the flow comes to a standstill. The other important thing, and which actually drives the length of stay down, is that the same clinical team who are in the frailty assessment area are also looking after the short stay beds. So the same group are doing the board rounds the next day on the short stay unit. And the reason why that is important is because the same team have made the plans. So the plans, they simply make sure that the plans that they have made are actually carried out. The other interventions we did was gave them leaflets at the very beginning at the ambulance drop-off when they were picked up. The leaflets were given to the patients and their family to set expectations. Initially to say they may not be admitted, they're simply going to be assessed. The families often said, okay, if you're not going to admit the patient, then we'll wait and we'll take mom back home, or we'll take our relative back home, which was great. We kept the patients in their own clothes while the assessment was being done, and this was good because we didn't need to have male and female bays, and we could assess patients in an environment which was suitable for both. Now, again, this was very important. Those patients who were assessed to need a short stay in the frailty short stay area, all their admission paperwork was done in the assessment unit before being admitted. So every patient who went into the short stay beds had a full CGA done. there was a good medical plan, there was a physio plan, there was an OT plan, the pharmacy drug reconciliation was done. So everything was done, and then they were sent into the ward. So once in the ward, the nurses didn't have to chase OTs or physios or junior doctors to do clerking. Everything was done. The drugs were written up, everything was done. All they had to do was simply just follow the plan and just make things happen. And that was important. Now, the patients who went home from the assessment unit or the patients who went home from the short stay unit, both of them got follow-up calls by the community teams. This was up to 6 days, or sometimes it went on for a few weeks, but the community teams followed them up once they went home, and this was something we agreed with our community teams. The other thing was that Warwickshire Fire Rescue Service helped us take patients home, especially those who were same-day emergency care. They took them home once their plan was made. And not only did they take them home, they did safety checks for up to 5 days after the patient was at home, which helped us with reducing the readmission rate. Now, this was our previous working model where there was an ED where the patients came. There was a medical assessment unit, a medical short stay unit, and an ambulatory unit. There was also a short stay frailty unit already there. And the whole team was there, but it was very differently placed. So the OT was based mainly in ED, trying to prevent admissions. The physios were in the short stay unit. Pharmacy was in the medical short stay unit. Social work was somewhere between the short stay frailty and ED sometimes. Nurses were, of course, only on the ward. And the ACPs and consultants, they saw the patients in ED, assessed them in the medical assessment unit, and then took them to the short stay unit. So the patient followed the same pathway. They were assessed there and they were taken there. And this was not optimal. So in the current working model, what is happening is we have introduced this new space called Frailty Assessment Area. This is where it is unisex, where there is no bay. It's a bay where there are beds, trolleys, chairs, a combination of them to suit whatever the sort of patient group that we're bringing. So the ACP, the Frailty ACP, is based in the ED, as you can see. At the ambulance drop off, they pick the patient up and bring them straight to this assessment unit. So here we have the rest of the team, the OT, the physio, the pharmacy, the social work, the nurses are there. And most importantly, there is a consultant here. Now, as you can see, two things. One, we've used the same resource which was there before. So in other hospitals where they say there's no resource, actually the resource is there. It's usually spread out. And what we did is just brought the same resource into one place. The second important thing is that having a consultant there. Now, this can be a consultant who is got an interest in frailty. It can be a geriatrician who's interested in frailty. It can be an ED consultant who's interested in frailty and is trained there in frailty, or an acute physician who's interested in frailty. It can be a GP as well. And the reason why the senior clinical decision maker and a consultant or a consultant backing up this entire MDT is important is because it allows the criteria that the MDT normally used to be dropped. If this consultant was not there or this medical backup was not there, then the ACP here would have very strict criteria for bringing patients here, and you wouldn't be able to pull a lot of patients. So if somebody was having a temperature of 38.8 or a little AF, they would not meet the criteria because they didn't have anyone to do a medical assessment and a management plan here. So the number of patients coming through here would be minimal. Having a consultant there under whom the patient can be admitted into a short stay ward if necessary is really important in getting bigger numbers through the ED into this area. And I can't emphasize the importance of having that person there. And other places, it has actually failed because of the lack of this. So the patients from ED who go through here are admitted under the acute physicians. Patients who come here are admitted under this consultant lead whoever that is, normally a geriatrician. So once they are assessed there, the aim of this entire team is to get the patient back home in the shortest possible time. And this is where the Formula One, pit stop approach is. So once they're assessed, some of the patients can go back to their usual place of residence. So you've managed them as same-day emergency care. And another group need to be admitted for a short while, which is a short stay frailty ward. Now, this is where, as I said, this team needs to have control on the beds here. If they don't have control on these beds here, they can't admit patients from here, and that is it. Then the frailty assessment unit gets blocked. So because the same team do the ward round next day morning, they know how many patients are going, how many beds they can release, and they keep the beds for those who are coming from here. And that's really important. Now, this is a big team that needs looking at. This is the amount of MDT that can work on every single patient. So there's an ACP, there's a nurse to give medication, because they spend a lot of time in the unit, up to 8 hours sometimes. They need to be given their regular medication, so you need a nurse. There's a doctor, there is a HCA, there is an OT, physio, pharmacy, social care, voluntary sector, the community emergency response team, and the transport. It can be, the ambulances or Warwickshire Fire Rescue Service, as in our case. So this entire team needs to have a coordinated approach, and they're continuously talking to each other in this FAA. So things are happening real time in this place. Some results of that sort of working pattern. The process time, as we can imagine, from the time the patient comes to being triaged, to having a decision made, seeing a consultant, all that is really quick. And it's no big surprise as to why it is quick, because things are being done with that attitude that we want to send this patient home as quickly as possible. So the time to see a consultant is usually less than 3 hours in most of the patients. And the average time that the patient spends in the FAA is usually 6 hours, average. Now, in 6 hours, the patient has either left to go home, or they have been admitted into the short stay unit. So one of the two happens. Of those, so this is that half of them are, and in our PDSA that we did, half of them were discharged home, and the other half got admitted into various places. This is our short stay ward. This wasn't our short stay ward, but as you can see, this was what we needed, and eventually we did take off all those beds as well. So you needed more beds than what we originally had. But these were our admissions, and these were the patients who went home. Of those who went home, the majority of them did not need any extra support. They didn't need any extra OT or any community support. A small proportion of them needed the community emergency response team. Some needed some equipment to be ordered, but majority of them didn't need anything. And these were the admitted patients into various places. Now, when we did that PDSA, we did it for 2 weeks, and this was our, data on that. So these were our over 75 medical admissions previously, and in the 2 weeks that we did, we dropped our admissions dramatically. There was a step change in our admissions. So in those 2 weeks, we admitted 9 patients or less each day, and we did that only 18 times in the last 2 years. On 18 days, we did that. So this we thought was quite significant. And that gave us the strength to carry on with the PDSA. While the business case was being made to get the team's numbers up to be able to work 8 to 8. Remember, this team was only working 9 to 5, 5 days a week. So now we needed a team to work 8 to 8, 7 days a week. So a few more results. Now that PDSA was over, and then we had the business case, and now it's business as usual, and I'll just show you some results. So our attendances of the patients over the age of 75 are going up, as is everywhere. The attendances are going up, but we are admitting less. As you can see, our admissions are dropping. There are a few weeks that they have been higher up, but they keep dropping. So the number of patients we are admitting is less. This is no surprise. You can see that big step change in the performance, A&E performance, because as I told you in the very beginning, these are the patients who spend the maximum time in the ED cubicles, blocking, I hate to use the word, but blocking some of the ED cubicles and leading to, a worse performance in A&E. Now, taking this group off, which normally drags down the ED performance, out of ED really helps with our ED performance. What I have to really emphasize at this point is this was not the reason why we did the trial. It was because ED was not the right place for these patients. That's why we brought them out, not because we wanted to achieve this. And I really want to make a point about this. This is not about, doing the wrong thing for the patient. Now, the length of stay on these patients has been dropping. As you can see, it's been dropping, and it continues to drop as well. So you can see this is the entire emergency admissions. This is all emergency admissions, and the length of stay has dropped. And in the over 75s especially, it's coming down more than all of it. And this is our stranded patients. So over 21 days length of stay patients are also, as you can see, continuously dropping with the continuation of the PDSA. It's not a PDSA anymore. As I said, it's business as usual. The detox in the community and in the acute are coming down. As you can see, we're not admitting many of the patients who don't need to be admitted, and managing the patients who we can turn them around really quickly. But the reattends have stayed the same, and we are not ashamed of it, because we think that if we are taking risks and we are sending patients home early, sometimes we fail only not because they medically have to come back for a medical reason. We fail because we haven't been able to give them all the support that they sometimes need in the community. So that's some of the reasons why they come back, but we still keep them in the front and still aim to send them home as soon as possible. Now, this is something which was really quite poignant when we did our PDSA. This was our acute medical unit. We have about 30 beds there, and our normal over 75s there were about these. And you can see in the 2 weeks that we did the trial, the over 75s in that age group in our acute medicine dropped dramatically. So that released a lot of beds. So you can see the beds were all empty, half the beds were empty, and they're taking surgical over 75s in that area. So basically, it released a lot of capacity in our acute medicine. The nurses were really happy that they didn't have, they had beds empty, and they started pulling more patients from ED. So because the nurses were freer to care for sicker patients, in the past, they would not pull patients from ED who were very sick because they didn't have the nursing resource to look after. But now that they have released the nursing capacity, they actually pull patients who are sicker from ED much faster. There are lots of other benefits within the frailty wards, because the patients were going to these wards with a complete management plan, and the patient and nurses on the wards did not have to chase physios, OTs, junior doctors and everything, and they just did what was the plans, followed the plans. The discharges from those wards also increased by 26%. There was a decrease in pathway 1, because pathway 1s are the ones which we are sending patients home with support. Many more patients went home with no additional support than previously. Now, there was some saving on overage investigations, which normally happens when the patients go through ED. They have lots of investigations done before they even hit acute medicine sometime. So, but the Frailty team will be making sure that the right investigations are done. So we could have saved a lot more on investigations as well, which we haven't evaluated. Now, there's excellent feedback from the staff. They really enjoyed, the Frailty staff themselves enjoyed doing this and making a difference to the hospital. Patients loved it because they spent little time waiting in ED. ED staff overjoyed because their cubicles were empty. Acute medical staff, I showed you how, the acute medical unit was half empty. And this is where, when you make business cases, you need to see whether you can actually redistribute the resource than asking for more resource. So because you've saved some of the resource in acute medicine, could you actually shift some of the workforce from acute medicine into Frailty? This is something to think about when we're making business cases for Frailty pathways. Now, this was following on to the PDSA. We had to do a prediction of how many beds we would save by carrying on with this pathway. Now, as you can see, there are a number of ways of modeling it, and you can model it based on two things: the number of patients that you have not admitted. So by stopping the admissions, what will you save? And by decreasing the length of stay, by managing them very quickly and efficiently on the wards, by the same team, by giving continuity of care and making sure the management plans are being progressed quickly, that is another way of bringing down the length of stay. So if you look at both the ways, how much beds you will save, by decreasing the number of admissions, you save actually not a lot. You save only 5.8 beds. But by decreasing the length of stay, by rapidly turning over those, by keeping them in the right place, getting them managed by the right team, getting the management plans done very quickly, that the prediction was, the bed saving from that was 26. So, and in reality, last year, we saved around 24 beds. And that was perhaps due to the Frailty pathway. We can't be 100% sure because all sorts of things come into play. But what it is every year we need a whole ward normally as a flex capacity ward in winter. And this year we didn't need any extra flex capacity, which was great. So that is why we think that the Frailty pathway has actually saved all those 24 beds. Now, even if we did have the flex capacity, even if there was funding available to have an extra ward, we couldn't manage to resource it properly with the right staff, or the nursing staff or the medical staff. So that was the other point that we would have failed, but we didn't need anything at all. The feedback from everywhere was amazing. In addition to all this, we made a GP WhatsApp group as well, where all the GPs from the Federation and the Frailty team were all in one WhatsApp group. So they were feeding into this as well. So there's feedback from everywhere, as you can see, which was amazing. So thank you for listening. And any questions?
Jyothi, that was a brilliant presentation as ever. So, which I've heard before. It's always great to hear again. I've just got a couple of questions, if that's all right.
Yep.
So just, this is a great piece of improvement work. Did you have any dedicated service improvement resource to help?
Yes. We have a quality improvement team, and I'm part of that. This is my role, as I said, as my job is QI, and I have helped this team in setting up the PDSA. And more importantly, lots of people do work, but they're not able to prove that they did good work. So having the business analyst that I work with as part of this team really helped, because he knew right from the beginning what was being done before, what was the change, and how to collect data to show whether the improvement that they made actually made a difference. So the team went tasked with collecting data, which is one of the biggest things which people make they make a mistake of asking the busy clinical teams to collect data as well, and they can't do it. And it's difficult for them to do. So that should be taken. Let them concentrate on doing the job, and somebody else collects the data and just gives it to them, and gives it to them real time. So by the time we finish the 2 weeks PDSA, by the end of that week, we already had these graphs. So that really gives the confidence for the team to say, right, we are making a difference, let's keep going. If we got the results 2 months down the line, they would have forgotten what they have done. They would have lost interest. They would have gone back to their own ways of working. So timely giving of these results is really important.
Yeah, that's great. And so you increased capacity from 8 a.m. to 8 p.m. And you did talk about a business case, which wasn't just about we need more resource. We want to use the resource we've got slightly differently. But did you use more resource to do this and to implement it in a sustainable manner?
Yes. So we did the PDSA in May, and we started business as usual from October onwards. So in between May and October, they carried on with the same process, but 9 to 5, because they could not resource until 8 o'clock. And the business case, it didn't need convincing anybody. It was just so obvious that it would give us the results. So it was passed through, and we were allowed to recruit even before it formally went through the process. So we were allowed to recruit, and we did recruit. So there was a need. But what I'm saying is, if we had thought about it carefully, actually these patients were looked after in the acute medicine unit before. They were not coming to the frailty unit, they were coming to the acute medical unit, and they were being looked after by them already. And as you saw, acute medical unit was actually half empty. So whether we can actually be cleverer in future and say, can we redistribute the resource rather than asking for new resource? You still need something new because the hours are more, but whether we could use the medics from acute medicine to come here, or we could use the junior doctor workforce, we could do a number of things if we share that friend of resource.
Yeah. Okay. Thank you for that. And just another question is, so you talked about the clinical teams within this part of the hospital in terms of the frailty pathway having control of the the decisions to transfer and admit. That I think in our experience that's not that common really. So tell me about the thinking behind that, and also the reaction. Was there a reaction from the site management team, or how did you get that one through? And because that one seems quite a significant one to me.
Yes. So what site management can't digest is the word ring fencing. So once you say we want to ring fence, they don't like it. So they don't like the thought of beds being empty when they have patients queuing in ED, which is, I absolutely get it. What we are saying is we are not going to keep any beds empty. We will make sure that patient, instead of, just imagine that FAA is full and the next patient needs a bed. Now that patient would have gone to some other place in the hospital in a bed. But what we're saying is, instead of that happening, we will put them in our frailty unit in the right place. So we will make sure that they will come to the right place so we can look after. So all the beds will be occupied, but they'll be occupied. The team will choose, cohort the patients in the right place. And that is all we are saying. So as long as we can convince the site management that you will not have empty beds lying in the frailty short stay unit all night while the ED is heaving, we can convince them. That's the only way I can.
Okay, great. Yeah, that's someone coming in there. One last question. So I really liked when you had a graph up about readmissions. So tell me the view about readmissions, and you sort of, I think you mentioned the word about, so they didn't go down. I think they may have, at times they may even have gone up a little bit. So just tell me about the thinking around that, because most people are like really sort of strict about, well, readmissions can't go up, and you sort of talked about being a little bit less risk averse. What are your thought process around readmissions as a balancing measure?
Yes, when we do new things and we are sending patients home who are not recovered but recovering, we sometimes need more help at home to during the period that they are still recovering. So currently what we do is, until the patient is fully recovered, we don't send them home. But what we are saying in this PDSA, what we try to do is, if somebody has a mild temperature and they're still a little bit unsteady on their feet, as long as they pass the physio and OT, we are sending them home. But they still need some more support at home, and that support at home may not always be as much as we hope it will be. So they may have another fall at home, and then that may prompt another 999 call, and they may come back. So yes, that happens. We can't sometimes keep people 24/7 at home. That means they will need more than 4 times a day care. Means that's a different level of care. Sometimes some of the equipment which we think should have gone hasn't gone home at the right time. So that's our fault, and we didn't check that sometimes. So the reason for them being readmitted wasn't always the fact that they medically were unwell. It was because the right support could not be arranged, or we underestimated sometimes the support that they need at home. So that's why they came back, and that's not, and it was learning for us. As we were learning. The community teams got more competent, more confident, and they put in more visits as and when necessary. So we learned from there.
Brilliant. Okay, Jyothi, that's all the questions. Just like to say a big thank you for this webinar. And if you want to contact Jyothi for any information or any help, you'll find her contact details beneath this video. Okay, thanks ever so much.